The information presented in this program is offered for educational and informational purposes only and should not be construed as personal medical advice.
Good afternoon. Glad that you could all make it down here. We've got a great presentation for you here. We've got Alyssa and John are with us. One's an occupational therapist, another one's a physiotherapist, and they handed out some handouts for you. They've got some other great information for you, and there will be maybe some demonstrations a little bit later. And so I just want to welcome you here, and I'll turn it over to John and Alyssa here.
Hi, everybody. So I'm Alyssa, and this is John, and we work at Home Care. So I'm the OT, and he's the physiotherapist. We do a lot of work with people around falls. I do a lot of work in terms of home accessibility and helping people manage their activities of daily living. So that's everything you need to do, getting in and out of bed, getting dressed, all that sort of stuff. And John does quite a bit with mobility and exercises and that sort of thing. So today we're going to talk to you about fall prevention. So first of all, we're going to start off with some statistics. So expected fall rates, we can expect about 35% of our clients in the community through home care to have experienced falls, and about 20 to 30% for older adults living in the community who don't have home care involvement. So falls were a cause of 57% of injury-related hospitalizations, and 90% of all hip fractures in seniors are as a result of a fall. So what is a fall? It's an unexpected event where a participant comes to rest on the ground, floor, or lower level, and it can be with or without injury, and so slips, trips, or falls. And so this doesn't necessarily mean that you're going to wind up on the floor if you have a fall. Perhaps you stand up too fast and you have to sit down really quickly in your chair again, or you're getting in and out of bed and you do happen to fall over onto the bed. Those are still considered falls. So these may include unwitnessed falls with evidence that the fall has occurred, but the client cannot explain what happened. And so this might be the case in a person who has some cognitive impairment, a sort of dementia or something like that. If they may have a fall, they might have some sort of an injury, but they can't explain what happened. This might also include a near fall where a client is lowered to the floor by staff or family members. This might happen if a person is unable to walk by themselves and they're getting assistance to transfer a walk from somebody, and they're getting support, and so they don't fall down hard, but they realize that they're going to fall and they might be gradually lowered down to the surface. And this includes near falls where a client loses balance but is able to catch themselves before falling, and so this is what we would consider our trips, basically. So we have 5 components of falls prevention at Home Care. First of all, we screen clients for risk of falls. We have a fall risk assessment that we can complete when we get a client referred to us at Home Care. Next, we would assess clients at risk, and so John and I do home visits. We go into the person's home and we might assess the areas that they're at risk for falls. We create a personalized care plan. So after we determine what people's fall risk is, we might look at different equipment to help them do their activities of daily living or mobility, or exercises to help them maintain their strength and balance and that sort of thing. We would document, educate, and evaluate the falls risk, and then we would do prevention. And so basically we want to avoid having more falls in the future.
Great, thanks, Alyssa. Does anybody know what the most dangerous thing in this room is? This microphone, because I may start singing and it may cause damage to your ears. I don't know if any of you guys do any karaoke. We might do that after the presentation. Can I get a hands up if anybody wants to come and sing? Okay, I'll convince you later, don't worry. All right, so Alyssa and I will be bouncing back and forth between the presentation, and feel free to ask questions as we go along, but we've got a lot of stuff here for you. So, what I'm going to start with is screening clients for falls risk. So when we're looking at someone, we're going to say, well, is this person at risk for a fall? We're going to look at this. Have you had 2 more falls in the past 12 months? So you can ask yourself this as well. Have you fallen 2 or more times in the past 12 months? Or have I had a fall that required medical attention? So those are kind of things that if that happened to you, you know what? You're at a high risk for falls. Did you have a recent fall within the last 6 months? Or do you have any difficulties with your balance or mobility? So just a show of hands, does anybody fit any of these criteria? Okay, so in this room there are some people who are at risk for falls, and I think that's why we were brought in, so it's great. Okay, our next slide here is assessing clients at risk. So multidisciplinary, multifactorial risk assessments. What does that mean? Well, that includes a client history, polypharmacy, so what medications you're taking, especially if there are more than one, vitamin D, which goes with bone health, a physical exam, cognition and mental health, postural hypotension, which is, you know, that sensation of sitting up and feeling a little bit lightheaded, vision and feet, functional assessment, and environmental assessment. So as you can tell, a lot of things contribute to risks of falls and things that we need to know about. So client history. So what do we want to know when we are talking to someone? The history of falls. So when did you fall? Where did you fall, and why? Was it slipping on the ice? Was it dizziness? So there are many reasons for falls, and that's something that we need to know. A medical history, cardiac conditions, so if there's any heart conditions, respiratory issues like breathing issues, osteoarthritis, osteoporosis, or any recent surgeries. Oftentimes, after a surgery, you're feeling a bit weak. You may be at higher risk for falls. Different types of cancer, and even incontinence. Those things that we'd like to know. Polypharmacy, as I alluded to before, is you are at more risk if you are on 4 or more medications and or psychotropic medications. Medication review with a pharmacist or physician every 6 months. That's very important. Who here goes to their pharmacist every 6 months for a medication review? Well, 3 is not bad. I'll try to increase that. Can I, if you don't mind me asking, how many of you are on more than 4 medications at home? Okay. And there are certain medications that are cautioned against for use of seniors. And some of these medications can affect your blood pressure, can affect your balance, and can cause dizziness. So we have to be careful with those as well.
All right, so vitamin D is very important in seniors. If you have weak bones, you're at increased susceptibility to injury, and vitamin D basically helps calcium absorption, which helps keep your bones healthy and strong. So if you have a lack of vitamin D or calcium, it puts you at risk for vertebral compression fractures, and these might occur if you have a fall, or sometimes they just occur because of degeneration of the vertebrae. It puts you at risk for kyphosis, which is basically rather than having a nice straight upright posture, it's having a hunched over posture like this, which makes it quite difficult to walk. It makes it more difficult to hold onto a walker, a cane if you use it. And so the recommended dosage of vitamin D is 1,000 units, and calcium is 500 milligrams. And so before you take any medication, it's important that you talk to your doctor about it, even if it is just a supplement, because sometimes they may have interactions with some medications that you take. And so always talk to your doctor before you start any sort of a supplement, or if you see a nurse practitioner, they can give you information about that as well. Okay, and so a physical exam can include a range of things. One thing that we would want to assess is your gait, and so that's basically how you walk. And so we would want to determine if you have a typical gait or if you have a limp, and if you need a gait aid, what kind of gait aid would you need? Would you need a walker or a cane? We would also assess your range of motion and strength. And so your range of motion is essentially how your limbs move. And do you have enough range of motion to be able to do what you need to do, or is it limited? And we would also want to assess your strength. And so if you have a weak upper or lower extremity, you might not be able to stand up properly, you might not be able to walk properly, and you might not be able to hold on to your gait aid if you have one. And so we do a few different assessments to determine what kind of gait aids would be appropriate for people. The one that we do in our falls risk assessment is called the timed up and go. And it's just a very quick assessment, and it helps us determine if people need a gait aid or not. We would also want to assess your static balance and your dynamic balance. Your static balance is your balance when you're still, and your dynamic balance is your balance when you're moving, essentially. We would also want to take into account if you have one-sided weakness. If you have had a stroke, then you may have what is called hemiplegia or hemiparesis, where one side of your body is weaker than the other, and that can really affect how you walk. And we would also want to assess pain. If people have chronic or acute pain, this can really affect their ability to transfer, mobilize, and complete all of the tasks that they need to do safely. We would also assess cognition and mental health. So that's more of my role as an occupational therapist. If a person has cognitive challenges, it does put them at more risk for having a fall. One of the things that can be affected is attention. And so just ability to attend to your environment around you, to notice if there's tripping hazards or something that you might slip on. Your memory may be affected if you have a diagnosis, and so that might influence your ability to remember to take your walker or your cane. Sometimes people, if they haven't used a walker or a cane for their whole life and it's a new thing to them, they often won't remember to take it if they're up and walking around. So some of the assessments that I would complete are called the MOCA, the Mini Mental State Exam, and the EXIT. And these are various assessments that might just quickly assess cognition, and some of them are more in-depth and assess executive function, which is problem-solving skills. So people with a diagnosis of dementia or cognitive challenges may have difficulty with new learning, and so unable to remember how to use a lifeline after a fall, or inability to remember to bring their walker or their cane. Depression and anxiety has also been correlated to have an increased risk with falls. Okay. Next, we're going to talk about postural hypotension, which is what John mentioned. It's that kind of feeling you get when you change levels really quickly and you sort of start to feel lightheaded and dizzy. So a client would lie down in bed for 5 minutes and the blood pressure is measured. Then the client sits up and then the blood pressure is measured immediately again. And if the blood pressure drops more than 20, then the client has postural or orthostatic hypotension. And so basically that means that the person is at an increased risk for falls because the blood isn't getting to where it needs to go in time. So for these people, we will usually recommend that it's very important when you move from lie to sit or from sit to stand that you take a few moments and make sure that you don't feel dizzy or lightheaded before you go ahead and start mobilizing. So symptoms of this include dizziness, lightheadedness, nausea, disorientation, headache, and blurred vision. And so if you experience any of those when you change your levels, you may have hypotension. So treatment for this would include a med review, such as antihypertensives, and so this would be your doctor, your pharmacist, or the nurse practitioner, education about getting up slowly, and external transfer support such as a bed rail or a Saskapole by the bed, and I'll go over some equipment in a little bit and just show you what's available.
So just looking at your vision and feet. So vision's very important. Ideally, you're being checked every year. A risk of macular degeneration, glaucoma, or cataracts, or even diabetic retinopathy can affect your vision. So very important to have that vision checked regularly. So I hope you have a good relationship with your optometrist. Maintenance of your feet. So removal of calluses or corns, bunions, keeping toenails trimmed, or addressing sores immediately, very important. Also having the proper fitting orthotics for your feet as well, very, very important. In terms of your feet, your shoes, they should be well-fitting, ideally non-slip, and secured well to your feet. So whether they be laced up very well or Velcro shoes, very important. In terms of functional assessment, look at things like transfers. So how do you get to your bed? How do you transfer to your chair, transferring to a bath, or even the toilet? Activities of daily living, cooking, laundry, housekeeping, all those are important tasks that can lead into a potential for a fall.
Okay, so when we do a home visit and we're assessing fall risk, we want to do an environmental assessment. And so we want to look at trip hazards, lighting, accessibility, railings, the bedroom and the bathroom layout, and the chair and the bed height. Trip hazards are obviously things like throw rugs. Those are always really difficult. Do you have smooth transitions between your rooms, and so like from carpet to linoleum? Do you use oxygen that you might trip over? Lighting is very important. It's really good to have a well-lit home so that you won't slip or trip on something. But one thing that people will often miss is at night. If they have to frequently get up to go to the washroom, they won't have a well-lit path, or they won't turn the light on because they don't want to disturb someone else. So it's really important that you have a little night light or maybe a flashlight that you can take with you to prevent you from tripping. Accessibility, and so like I said, smooth transitions and thresholds in the doorways, and also, are you able to complete your stairs to be able to get into your home? A lot of times that's something that becomes really difficult for people as they get older, and so do you need to look at getting a ramp into your home, or moving into an accessible home that is elevator accessible, or that sort of thing? Railings and stairs are very appropriate. It's always important to have a railing on all of your staircases, at least on one side. A lot of people find that when they get older, they have to start using a railing on one side and a cane on the other to be able to do the stairs properly. And railings are just a good idea for everyone, I think. And the bedroom and the bathroom layout. Do you have a nice clear path for you and your walker or cane if necessary to get through, or is there stuff that you might trip over? Your chair or your bed height. And so if you have a very low chair or bed, it might be very difficult to move from sit to stand, especially if you have one like this that doesn't necessarily have armrests. And so we might look at increasing the height for people to transfer a little bit easier, or again putting external transfer supports in, such as a floor to ceiling pole or armrests or something like that. So in creating a personalized care plan, we use the BEACH model. And so for education, we have a Looking into Falls info sheet, and I believe that that's at the back of your handouts there. We have the home safety checklist, which we also have included in there. And so we would encourage you after this to go over the home safety checklist and look at what areas you might have that could put you at risk for falls. And you can do this at home too. And if you do find that you have any concerns, request a consult for an OT or a physiotherapist. What equipment is already in place and what equipment might be needed to help make people safer in their homes. Activity, and so what exercises can be prescribed to maintain balance and increase strength. Clothing and footwear, so are you wearing appropriate shoes? Are you wearing appropriate clothes that you're not going to trip over? Are you making regular foot care appointments, particularly if you have diabetes and peripheral neuropathy? And health management, and so are you having regular visits with your family physician or your nurse practitioner? Are you having your medications reviewed and taking your vitamin D? And so we do encourage people to see their healthcare providers regularly, just to be able to decrease their risk of falls in these ways.
Okay, just looking at falls education. So did everybody find that handout in their package? It's probably in the back, but everything that we're providing on screen and the handout should be in the package. So after this presentation, when you go home, and if you have any, if you've forgotten anything, just take a look at the package, okay? So looking at falls education, did you know falls happen to 1 out of 3 seniors living in the community who are 65 years or older? Falls can cause major injuries such as fractures. I think we all know that. And falls are preventable. So with enough care and enough attention, we can prevent these falls. So we can prevent falls by seeing your doctor or pharmacist every 6 months, as we talked about before. Very important to make sure your medications are correct. Ask your doctor if you should take vitamin D. Get your eyes checked by the optometrist every year. Have different glasses, sorry, it says classes, different glasses for walking and reading. So not bifocals, because that can actually throw you off a bit more. And using a walker or a cane if necessary. So In addition, we can wear well-fitting and non-slip shoes. We can take care of our feet, keeping our toenails trimmed, not our nose, okay? Treat corns and calluses by a professional. Stay active and exercise. One of those things is you want to always stay as active as you can safely. Because it's true, if you don't use it, you lose it. Who believes that? Just, 8 of you. Good. The rest of you? No? Okay. Drink lots of water and have a healthy diet. So that doesn't include cruising to McDonald's. I know. I've got to correct my diet. It's one of those things I do. And complete the home safety checklist. So definitely, when you go home, see if things are where they should be, or if there are things that are risky that shouldn't be there. Okay? And speaking of home safety checklist, which is also on the handout, check inside your house, check your bedroom, bathroom, kitchen, stairs, and outdoors. So basically, check everything, because people fall in all of these areas, okay?
Okay, so now what I'm going to do is I'm just going to go over some of the equipment that's available to help prevent falls and just increase independence with mobilizing and completing activities of daily living. So some of the equipment we have here today, but some we don't, because I have a tiny little car and it didn't all fit in. So the first item is a Saska pole, and I don't have it here today, but it's basically a floor-to-ceiling pole. They are available through the Abilities Council with a prescription by an OT, a physio, or a doctor. And basically the way they work is you can put them by a chair or by a bed, and it's something to hold on to when you complete a sit-to-stand transfer, or you can use it by the bed to help you move from lie to sit. And so it's just something to provide extra stability, or if you do have decreased strength in your legs, you can use your upper body to help you get up a little bit more. Before we go on to the commode, I'm just going to talk about one other piece of equipment that helps with bed mobility. And so this is called an M-rail. And so this is an item that you would have to purchase, but the way that it works is if you don't want to have a floor-to-ceiling pole, this rail fits between the box spring and the mattress of your bed, and then it hooks over top to make it nice and secure. And so if you do have a hard time moving lie to sit, it will help you pull yourself using your arms and just make it a little bit easier. So they sell those at most pharmacies, Canadian Tire, Walmart, that kind of stuff. We don't endorse any one vendor over another. So the next item I'm going to talk about is called the commode, and it is available through the Abilities Council with a prescription as well. And so basically what the commode is it is a toilet chair. You can either get them with standard legs that elevate in height, or you can get them with wheels on them. But basically the way that it works is it prevents people with urinary or bowel incontinence from having to get up and mobilize all the way to the bathroom in the night if that might be a fall risk for them. And so a lot of people use them at their bedside if they're feeling quite ill and their mobility is poor, or sometimes people will use the height adjustable ones over top of a toilet to increase the height and provide some arm rests. So another item that people use to increase the height of the toilet is the raised toilet seat here. Now, this would be an item that you would have to purchase, but basically it sits on top of the toilet, and the ones that I like have a nice knob on the front that attaches to a lever, and so it makes sure that it's nice and fixed and secure on the toilet, and it just increases the height. You can get them with armrests too if you want something to be able to push yourself up. It's very important with these that they are nice and secured on the toilet. We have had or I've heard of some incidents before where it's not secured and the raised toilet seat falls off of the toilet with the person. And of all the places in the house to have a fall, the bathroom is probably the worst because everything is hard and sharp and cold. So next we're going to talk about a bath lift. A bath lift is also available through the Abilities Council, but only for specific people with specific diagnosis. And so in order to get a bath lift prescribed, we would have to say that a person would have COPD or congestive heart failure and not be able to tolerate a shower spray, or they would have some sort of a skin condition that would require them to soak, or their bathroom wouldn't accommodate any sort of another tub seat. And so they're not available to everyone, but they are available to some people if you do like to get in and out of the bottom of the tub. We just can't prescribe them for people, say, if you just prefer a bath over a shower. The next item I'm going to talk about is the transfer tub bench. So it's available through the Abilities Council, and basically it just increases your safety transferring in and out of the shower. So the way that it works is 2 legs sit inside of the tub and 2 legs sit outside of the tub, and whoever is using it would back up to the seat and sit down, and then they would bring their legs over the tub ledge while they're sitting, and it just prevents you from having to stand on one leg to transfer over the tub ledge. So the way that you would prevent the water from spilling on the ground, which is another fall risk, is you would take the shower curtain and you would pull it across and sort of stick it under your thigh. So this type of seat doesn't work if you have one of the showers that has the sliding glass doors. Those would have to come off if you wanted to use this sort of tub seat. We also have just a standard shower chair over there. That is something that you would have to purchase as well. They're not covered through the Abilities Council. This is a height adjustable one, which is really, really nice because you can increase the height if it helps you move from sit to stand. This one is fairly small. You can get them a little bit bigger, and you can get them with backrests, which most people find is really nice as well. And so I think that that's it for, we also have a tub clamp grab bar here. So this is a grab bar that basically goes onto the tub ledge, and then you would turn the knob to tighten it, and so it just provides something to hang on to while you're stepping over the tub ledge. I don't usually recommend them for getting in and out of the bottom of the tub because they aren't permanently fixed. They're not bolted into anything. In the cases where you wanted something to hold on to help you get in and out of the bottom of the tub, I prefer these grab bars because they get bolted into the wall and you know that they're going to be secure. And so both of these would be items that you would have to purchase, but they're both nice for helping you step over the tub ledge and can be used really nicely with one of the shower chairs. So next we're going to talk about the walkers, and so we do have a walker here today, and this is called a 2-wheel walker. This and what would be called a standard walker are both available through the Abilities Council. The standard walker is the same, only it doesn't have any wheels on the front. So these are nice because they're light and compact and they fold up. Another type of walker that's available is a 4-wheel walker, and if you just look right there, that's a very nice example of one. Those are very nice walkers because they allow you to put the brakes on and sit and take a break if you like. They aren't appropriate for everybody. For some people with really limited mobility, the wheels get moving too fast, and so it's definitely something that you would want to discuss with someone first before you purchase it. They're also really nice for people who do happen to use oxygen because you can mount an oxygen tank holder on the front of them. So those are a really good option. They are a little bit heavier, and they are something that you would have to purchase is the only thing. Wheelchairs are also available through the Abilities Council, but this is something, again, that would have to be prescribed. There's a variety of different wheelchairs and cushions and adaptations that we can do to them, and they come in varying sizes. And so there's kind of 2 ways that people use wheelchairs. One way is for your primary mode of mobility, and so that would be people who use wheelchairs in their home because they don't mobilize at all. But then there are some people who do mobilize but find that out in the community they aren't able to mobilize far distances because of chronic pain or because they get short of breath or that sort of thing. And so in those cases, it's often appropriate to get a wheelchair for community access as well. And I think we already went over the transfer tub bench, and so that's just this item right here. So I think that that's all of our pieces of equipment. Does anyone have any questions about any of them? There's an Abilities Council in town here, yeah. There's one here, one in Saskatoon, and one in Regina. Yeah, and so all of the equipment that you would get through the Abilities Council, you would have to get a prescription from an OT, a physio, or a doctor, I believe. If anybody is treaty status, they don't get their equipment through the Abilities Council. Again, you would have to get it prescribed, but it goes through a different funder, and there's just a different amount of equipment available, and their stipulations are different. And so if anyone is treaty status and would like to speak to us about it, we can sort of explain that procedure as well.
What's the cost from St. Paul's Church?
Another item that we often prescribe for people is a handicap parking placard. And so if you do have decreased mobility and find that it's hard to walk a long distance, or in the winter if you use a walker or cane or feel scared that you might slip or trip, it is often appropriate to get a handicap parking placard. So we can do them temporary, and so say if somebody had a fracture and they're expected to recover and aren't going to need it forever, we can do a temporary one, or we can do a permanent one where you know that you're going to be using your mobility aid for the rest of your life and you're going to need the parking placard forever. Anything else that you can think of? Oh, and we had another page. So yeah, we went through the bath seat with no back, which is what that is. There's a bath seat with a back, raised toilet seat with and without arms. This one doesn't have them. The grab bars and the tub clamp bar, and we talked about the four-wheel walker.
Okay, so activity and balance. Maintaining strength is very important. How many of you are doing any kind of exercises at home? Very good. Anybody else? Great. Are these exercises specifically for balance? Or no? Okay. So definitely, one of the things that you can start working on is exercises that will help you stay safe, which are strengthening and balance exercises. So activities that also need to address balance are shifting of your weight, being minimally supported, static or dynamic exercises, or things such as, does anybody here do the Tai Chi? I know there's some people that attend a Tai Chi class here in Prince Albert. Oh, very good. Excellent. How do you like it? Excellent. Great. The thing is, walking is not enough. So I get a lot of individuals who will do a lot of walking, which is great. But there's definitely other things to be done in addition to walking that will help with your balance and your strength. Oh, thanks. Okay. This next part is documenting, educating, and evaluating. So initially you'll have an assessment, sometimes with an occupational therapist, sometimes with a physical therapist. For ourselves, just to stay organized and communicate amongst ourselves, we will often do chart notes or dated notes and fill out different forms through home care that are help to process falls. One of the most important things is prevention. So we can use, think of it as safe. So a safe environment, as we've mentioned earlier. So continually assessing your environment. You know, as seasons change, your environment changes. So keep an eye on the different environment. Ensure that all those risks are minimized. Assistance with mobility. So wearing your glasses is very important. Hearing aids, mobility aids are close by. That's very, very key, so that we're not always having to look for them. They're easily accessible. Fall risk reduction. So 3 questions you should ask before leaving. Are you having any pain or discomfort? Do you have access to your glasses, hearing aid, cane, or walker? Or do you need anything else before you leave? For us, engaging our clients and families is very important, so we'll often talk to clients and we'll ask them about what risk factors they think they have at home, and then we may make suggestions. And then after we've gathered this information, we'll try to implement a falls prevention plan. So it's always better to prevent. So from occupation,
From the OT perspective, we want to decrease reactive therapist involvement and focus on prevention. And so essentially we want to find out who is at risk for falls and make sure that we put equipment, exercises, and supports in place before a person has a fall. And so we perform a falls risk assessment on all new home care clients screened as falls risk. And so those receiving a long-term bath assist, wake-ups and tuck-ins, which is where home care comes and helps people in and out of bed essentially. And so it might not necessarily be us that does it. We do have a number of people titled as assessors at home care, and they're typically a social worker, but they are in other fields such as RN as well. And so they may be the ones who do the fall risk assessment because they're often the first person to be the home care contact. And so After we do the assessment, the client is assessed and we put the interventions in place. And so whether that be support, such as having home care staff come in and help you with your activities of daily living, or putting equipment in place to help decrease risk of falls, or an exercise program to maintain strength and balance. The client is actively followed up for 3 months. And so after they do the initial falls risk assessment, they will do a 3-month follow-up where they'll determine if the person has had a fall at that time. And if they have, then we have to review what is going wrong. If not, then everything is going according to plan, and the client's file may remain open for future intervention. And so other goals is increasing communication about clients. And so amongst home care staff, we try quite a bit to be able to refer to other staff members as appropriate if we think that they might be beneficial. And so say if one of the home health aides is doing a wake up or a tuck in with someone, and they start to realize that they're not able to get in and out of bed properly, they might do a referral to myself or John to see if any equipment can be put in place or any exercises that might make the person stronger and help them get in and out of bed. And so we try to refer where appropriate to decrease the risk of falls. We decrease duplication of services. And so essentially, John and I can do a lot of the same sort of things. And so rather than having a client wait for one of us to get a referral if the client is already on one of our caseloads, we may just try to do some of the work that is traditionally allocated to the other person, so that you don't have to wait as long for us to assess and do an intervention. And so, for example, the assessor might do the falls screening and assess for orthostatic hypotension. For myself, I might do a home assessment and prescribe exercises, even though it's more typically the physiotherapist who does exercises. And vice versa. If the physiotherapist is seeing the client rather than doing a referral to me, they might be able to provide some of the equipment that's necessary. The nurse may do the post-falls questionnaire and discuss medications with clients to see if there is any polypharmacy or anything that's having an adverse interaction. And the care aides may report if a person is having falls while they're receiving their care or their support, and they may assist with exercises that we prescribe if a person is unable to remember them or do them by themselves because we're not able to get in to do daily exercises or anything like that.
So this is very important, how to get up from a fall. It's something that's in their handout. So if you can find that handout, there's some pictures there that, that I'd like you to be referred to. Okay, so once you find that sheet, the first thing you want to do is, so I'll just give you a second just to find that handout. It should be near the back. So it's just how to get up from a fall. Everybody find it? Okay, perfect. So the first thing is prepare. So when you're on the floor, don't try to get up quickly, okay? Do not get up quickly. If you're hurt and you have access, call for help on your telephone or use your lifeline. So does anybody here, is anybody using a lifeline or, excellent, very good. Very good to have in terms of safety, something that can contact someone if you need help, especially if you're alone. Find something sturdy, such as a piece of furniture. So if you can find something that's sturdy to hold on to that will help you get up, that's very important. You're going to roll onto your side, turning your head, shoulders, hips, then your legs, okay? So that's the first part. You got to prepare for getting up. The second part is rising. So first off, once you found that solid item that you're going to use, you're going to push your upper body. You're going to lift your head, you're going to pause, and you're going to steady yourself. So remember, this is nice and slow. We're not trying to rush out of this. Take your time. Rise slowly onto your hands and knees. You're going to crawl to something sturdy that you can hold on to, the thing that you had identified earlier. Then you're going to slide 1 foot forward so it's flat on the floor. The third part is you're going to try to sit. So keep the other leg bent with your knee on the floor. Rise slowly and turn your body to sit in the chair. And then sit for a few minutes before trying to do anything else. So once you fall and you finally got to a sitting position, take your time. You're already sitting up, so in case you're dizzy, let that pass. So definitely taking your time in that sitting position. So one of the things we often ask is, well, what can we do? You've already told us walking is not enough. What else can we do to improve our balance? So there's another handout that we can just use for an example. Now, one of the things we want to say is these are just generic ideas. It's definitely important that if you're having issues, you go see your family physician, you talk to a physical therapist or an occupational therapist, because things might be specific to you, okay? But these are just some examples of what you can do. 2 or 3 times a day, you can slowly do slow toe taps, which is just basically tapping your feet on the floor. You can also, if you see the picture, hold on to an object, okay? A sink is probably what we recommend the most because it's the most sturdy. So you're holding on to your sink, doing slow toe taps, okay? Rising up onto your toes or a heel raise. So once again, you're holding on to the kitchen sink, and all you're going to do is you're going to raise your heels off of the floor. So you're going to go up onto your toes by raising your heels. Again, being safe, holding on to a counter. Mini squats. So while holding on to a counter, you can practice bending your knees and coming back up, okay? And this is a great one for balance, also fantastic for strengthening your lower body. Just walking on the spot. Again, if you're having issues with your balance, walking on the spot may be just a progression you need to get better. So just walking on the spot, especially if you haven't been able to do any longer walks, is a great start. Stand close to a counter so you have something to hold on to for balance if you need it, and you can just practice marching. Very simple. So you don't have to have any fancy gym memberships to get started. Alternate leg out and in. So basically what you're going to do, again, holding on to a counter, what we want you to do is practice bringing a leg out and back in. Out and back in. What that works on is your hip strength, which is very, very key for keeping your balance. If you have a weak hip, what happens is you'll have more likelihood of a limping gait, okay? So we want to make sure that our hips are very strong by practicing this, okay?
And so now we're just going to go over the occupational therapy referral checklist, or physiotherapy, depending on what the issue is. And so if one of our clients answers yes to any of the following questions that we talked about at the start, which is 2 or more falls in the past 12 months, just had a recent fall, which I believe is within 6 months, or difficulty with walking or balance, then that person may benefit from a referral to occupational therapy or physiotherapy. And so other reasons that a person may want to refer is a recent decline in functional status and or mobility, such as due to a hip or knee surgery or just a recent illness. Even a bout of the flu can put senior citizens at a risk for weakness, dizziness, decreased balance. It doesn't take much time spent bed resting to be able to lose some weakness or lose some strength. A new home care client who is accessing home ADL services, such as a bath assist or a wake up or tuck in, may benefit from some equipment to make that task easier. Another reason to refer would be for a wheelchair measurement or special equipment requests. And so if a person is finding that they just aren't able to mobilize with their gait aid anymore, or they would like a wheelchair for out in the community, that's usually an appropriate referral. We do always want people to try to maintain their mobility as much as they can. And any questions regarding home safety, such as cognition. And so I do get referrals sometimes for people if they start to notice that they're becoming forgetful, or their family members or any home care staff, they may refer to me to come and do a home assessment of activities of daily living, just to make sure that a person is safe, and so that I can recommend strategies to sort of increase safety. And there's several ways that people can get referred to occupational therapy or physiotherapy. You can speak to your doctor and they can refer to us, or you can contact home care yourself and you can say what your concerns are and that you would like to see occupational therapy or physiotherapy. In some cases, depending on how mobile you are and how able you are to access the community, they may do a referral to outpatients or to a private clinic instead.